you. Thank you, ma'am, and a very good morning to all of you. So definitely, we all know now that NGS is the need of the hour. I will just highlight a few important points, how it makes it different, how it impacts the decision of a clinician, because I'm a clinician and we have worked a lot with ma'am and we have learned lot of things from madam. So we know that uh, lung cancer is a disease. It is a mixture, it is a heterogeneous disease, and around 50% patients have some or other kind of mutations available. Just the thing is that you need to identify them properly. This is the impact of targeted therapy, which are we all are aware. Osimertinib, the data is huge. It can significantly impact the progression-free survivals and even overall survivals data with ALK inhibitors. Now we are talking about 5-year survivals very frequently. Initially, we were thinking whether to treat or give best supportive care alone around 15 years back. Now we are talking about 5-year survival. So that is the leap which we have made in the field of science, and that we also always say lung cancer is the poster boy of personalized therapy. Let's continue that. This is the standard algorithm. I will not go into detail of it. We are all clinicians are aware of the same, but the main point is that everyone should be able to do testing so that target can be detected. If you cannot detect the target, you cannot treat with a targeted agent, and targeted agent lead to a significant improvement in the survivals, which we are very well aware of. So there have been multiple studies even in early stage cancers, in adjuvant settings. So biomarker testing is now not limited only to metastatic settings. It has now come up even in early lung cancer, post surgery, now post radiation also it is coming up, and adjuvant treatment. So definitely it is making a lot of difference. We initially thought it is a thing only for the metastatic patients where we can offer only systemic treatment. No, now we know it is required even for patients who are undergoing curative intent therapy. So we need to be aware of all the things. This is the whole big list of mutations which we are very well aware of. Data from TMH is also available. When we see even a patient with EGFR sensitizing mutations are also different. We need to understand even single mutation which we have identified on EGFR by a COBAS version 2, there are many connotations to that. I will come to each one of them one by one. We'll see them. This is the problem. Tissue is the issue. Our pathologist senior, Dr. Rajiv sir, always tells that tissue remains the issue. That is why it is very important to have a parallel testing so that we can detect multiple targets at the same time and do not waste the tissue. This is what happens actually in the sequential testing. The tissue gets depleted. That is why we try to use minimal amount of IHC if required, even required. Sometimes IHC is also not required for characterizing adeno versus squamous, but when it is required, it can be done very limited panel so that you save the maximum amount of tissue for molecular testing. So why upfront testing matters? There is a great study available. Patients with driver mutations who receive targeted treatment versus who could not receive targeted treatment. You can see the outcomes are very well different. Survivals are between 18 months who could receive targeted treatment and had driver mutations, while those who could not receive targeted treatment when mutation was available, it was starkly different. At least half the overall survival becomes half when you are not able to use targeted treatment to treat a mutation. So definitely try to give the best possible treatment upfront. Don't wait for the second line, third line, because what happens, this is the real example, lung cancer, at least 30% patients will not be able to receive next line of treatment. That is why it is from a clinician point of view, I always try to use the best possible treatment. If target is always use targeted treatment, don't think if the patient progresses on chemotherapy, then I will use a targeted treatment, because what happens, at least 30% patient will not be able to receive next line of treatment. Why? Their performance status will become so bad that they will not be able to receive any treatment. So that should be kept at the back of mind while deciding any treatment. Don't think your patient is doing very well on chemotherapy and said later we can use targeted treatment. So this is a paper which we discussed recently. Anuradha ma'am asked me for the full text of this article. This is EGFR exon 19 deletion subtype, and a detailed analysis from China is now available for the same. It has been found that patients with EGFR E746 to 750 deletion, which is the most common deletion subtype, had a significantly higher frequency of acquired T790 mutations when treated with first or second generation TKI. While other types have somewhat lower frequency, so it helps us to identify what are the chances of having T790M mutations as well. And also there are some specific mutations, for example, 751 to 759, 751 to 756. These have different prognosis. These are sometimes missed by a COBAST version 2 test, and sometimes these are not even covered in the 42 mutations which are present in the COBAST. So it is important. Apart from exon 19, exon 14 mutations are also sometimes available. These can be missed by the RT-PCR. That is why it is important to do NGS. That is what I wanted to highlight. One slide more. This is the paper which we discussed in our last molecular tumor board. The beauty of molecular tumor board is that we keep on learning, we keep on enriching each other's self. So that is how the field is evolving, and it is always important to have a good discussion involving both the molecular oncologist, pathologist, oncologists. So that is the way to go. Never anybody can think I know everything, and we should keep learning. And this is what happens in our molecular tumor board. And this is another paper which characterized EGFR exon 19 C helix deletion. C helix deletion can be very commonly mixed with the RT-PCR test, and this is 2.5% exon 19 deletion occurs in the C helix part of exon 19. And for example, 751 to 759 deletion has PFS of around 2 months only. While there is clear-cut multiple case reports available, if you identify this mutation, if you treat with afatinib or osimertinib, you have PFS of up to 8 to 10 months. So just identifying the exon 19 is also not enough. You need to see what type of exon 19 it is. So this is the precision clinic, precision medicine, which we need to understand. Just getting that patient exon 19 deleted, this is also not now enough, because around 70% will be in the overall classical variants, classical types, but 30% might be some uncommon ones where we know we need to select differently, even in exon 19. We'll come to exon 20 later on. This is exon 20 that I was just talking about. Yes, exon 20 is also a very wide spectrum where we want to know whether a patient is going to have treatment benefit with TKI or not, whether patient deserves a treatment with amivantamab, which is now available. All multiple trials are available in India. TMH is also a participating center. So we need to understand each of them. And also you can clearly see the patients with exon 20 insertions who were able to receive first line TKI, sufficient TKI, the survivals are much better. So this is what I wanted to highlight again. If we identified exon 20 mutation or deletion or insertion by RT-PCR, that will not help us to decide what treatment has to be taken. If this is an NGS report where we can identify the exact site of insertions, then it becomes very useful. You can clearly see there are some sites which you can see it is sensitive to first line TKI. For example, you can clearly see this is 763 and 764. If you can identify it by NGS, you know it is sensitive to first line TKI as well. If there are some mutations, some insertions, which you can know it is sensitive to poziotinib or drugs like mobocertinib. Also, some sites like 773 and 774 are afatinib sensitive. So how you can decide to treat when you don't know which type of insertion is there if you don't do NGS. So that is the importance of NGS. Just knowing that there is an exon 20 insertion, it's like just again hit and trial method. You give one drug, patient progresses, then you give next drug, patient again progresses, then you give third drug. Might be patient is not able to receive that third line or second line treatment. So that is the benefit of doing NGS and identifying the exact type of insertions in exon 20, which is not possible by using a RT-PCR. So this was a lot about EGFR. We know MET exon 14 skipping mutations cannot be easily detected by other methods than NGS. Even we know DNA-based NGS, RNA-based NGS are different. RNA-based NGS holds a very important promise in identifying especially the fusions, and they remain the key to identify exon 14 insertion, exon 14 skipping mutations for MET. Similar is the case for other fusions like RET and others. I will be coming to some perspectives for immunotherapy as well. We are actively working on biomarker identification for immunotherapy in lung cancer, and I have applied for ISLC grant for the same as well. Hopefully, if we get some grant, we'll be able to do much more work on this particular area, because we know around 40 to 50% patients have mutations, but rest 50% we are not able to identify mutation despite doing an NGS. And even if we identify mutation, some are not targetable with the present available drugs. So the situation remains, out of every 2 patients, in 1 patient, you have to utilize immunotherapy and other drugs, not only chemotherapy. So PDL1 is always there. It has there from last 5 years, but whether it is able to actually predict, we know it. Even in PDL1 high, patient sometimes responds poorly. Even in PDL1 low, patient responds somewhat well. So that remains a problem. Biomarker identification remains a big problem. So there are some mutations which have been identified which predict the response to immunotherapy as well. STK11 and KEAP1 genomic alterations. There is clear data. If these are present, the survivals drop down. The progression-free survival with immunotherapy is highly dependent on these mutations or genomic alterations if present. There is clear curve separation. If these mutations or alterations are present, it will help us to know, yes, this patient is not going to do well on immunotherapy. So at least prognostic information will be available. Whether you have any other option, I'm not sure, but at least you will know this patient is not going to do well. So this is it is independent of the PDL1 levels as well. So if you identify high tumor mutation burden, high PDL1, but at the same time you are finding STK11 mutation or KEAP1 mutation, be very clear. This PDL1 and TMB is not able to predict the responses if these mutations are present. So it has independent prognostic value apart from PDL1. So PDL1 itself is not enough. We need to identify various other mutations with the help of NGS, even in patients who are candidates of immunotherapy. So this is same thing. I will be coming to now some recent paper. This has been published 7 days back only in the Nature Communications. This is a very good journal, and it has always tried to find some newer things which might be actually useful for the clinicians later on. So recurrent somatic mutations as predictors of immunotherapy response, another very good paper and deep insight. So they have found around 6 mutations, recurrent somatic mutations in not only lung cancer, but also in urinary bladder cancer and melanoma, where they found that BCLF1, that is BCL2 associated transcription factor 1. This is a marker which predicts poor responses to immunotherapy. You can see this curve is towards the lower side. That impacts clearly implies that these patients have poorer responses to immunotherapy. Similarly, TP53, we are very well aware of TP53. In our molecular tumor board also, we see a lot of patients with TP53 mutations, and we are analyzing the TP53 data separately in our molecular tumor boards. And we have now P53 mutations, more than 100 patients where we have identified P53 mutations, and we are looking to analyze them separately. So other mutations, KRAS and BRAF, these have been found to be somewhat favorable response to immunotherapy if these mutations have been identified. Odds ratio of 6 and odds ratio of 2. So this is the odds ratio on the left side. So odds ratio of 6 and odds ratio of 2 with BRAF, this have been identified. So this was the thing. So even with immunotherapy, you need to understand there are multiple somatic mutations which can help you to prognosticate the patient whether they are going to respond or not. So this is again BCLF1 mutation, which identifies even a patient who are having high tumor mutation burden but not going to respond with immunotherapy. So if patient is having a very high tumor mutation burden, still patient is not responding to immunotherapy, you can blame on BCLF1. And if you can identify that previously from the NGS or any other method, you can be understanding that this is patient is not going to do well. So to summarize, there is a clear data available that you need to incorporate NGS for best possible management of your patient. I clearly understand the logistic constraints. I clearly understand the various problems which are associated with doing an NGS, but doing NGS on large scale has led to coming down of the cost. And that remains the key. If you can do a test which is not for only 10 patients, it is for 100 patients of your institute per day, definitely it will change the cost of the test. It will definitely, if you are able to utilize the test in bulk, definitely the cost come down. So it is very important to identify the patients where you are able to do NGS, you are able to incorporate NGS in your routine practice. This is a big problem, and hopefully with support of our molecular team and support from TMH Medical Oncology team, we are able to surpass that. So choosing wisely remains the key in cancer always. Lung cancer is again a poster boy for the same. So you must choose, but choose wisely. And with that, thanks and greetings from TMH RRC. Thank you.
Thank you, Dr. Akhil, for a very comprehensive talk and highlighting many of the biomarkers which are coming up, like BCLF1, how important it is if you have a good tumor burden. The talk that is open for the discussion. Anybody having any questions can please. Amit.
So patients who have this STK11 and KEAP1 mutation, do you still want to give immunotherapy, or is it an absolute marker not to give immunotherapy?
We know that the PFS is around 2 to 3 months with these mutations. But if you don't have any other options available, you can consider, if you have any other option, for example, you are finding a mutation which has, for example, you find a patient who is having KEAP1 mutation, but at the same time, the patient has some other targetable mutation which is known to have PFS of 5 to 6 months. I will then utilize that option, because it helps us. It will help us to know that this patient is not going to do very well on immunotherapy. Also, while counseling as a clinician, we need to tell the patient that what amount of PFS or OS is expected while giving a treatment, because immunotherapy remains very costly treatment. And if I tell a patient that the average PFS and OS is around 10 months, but I know if there is a KEAP1 mutation or STK11, I will prognosticate and counsel accordingly. So as a clinician, it makes me and have a knowledge about the prognosis and counsel the patient accordingly. Because if I counsel the patient to say you will have a PFS of around 10 months, I hope that you will do well for 10 months, and the patient progresses only on 2 months, it will be like a failure of a clinician. But if this thing is available, I will be able to prognosticate accordingly, and it'll help me in guiding the patients.
Should we add chemotherapy with immunotherapy in this scenario?
There is some data now coming up where the combination of quadruplet, chemotherapy, immunotherapy plus bevacizumab, might be able to overcome some problems which is there with these mutations. For example, even in EGFR and ALK, we know the patients who have progressed on EGFR ALK based TKI, no further TKI is possible. ABCP has some data. So similarly, in these patients, I try to use ABCP if feasible. Thank you.
Questions? I have one question, just a question, like in your clinic, if you want to have NGS or first EGFR, because EGFR is a potential marker. So will you like to have the EGFR report at earliest, or you will wait for the NGS report to come where EGFR is also covered?
So ma'am, that depends on the turnaround time of NGS in your own institute. If you have in-house NGS and you know that the report is going to come in 2 weeks, it is fine to go ahead with NGS first. Because not doing EGFR is sufficient. But if I see that I have a turnaround time of more than 4 weeks, I would be happy to do at least EGFR and ALK, so that I'm aware that patient does not have a long waiting time before starting treatment. So that completely depends on the turnaround time, the logistics available.
Okay, and since you being at the Varanasi, how you come up challenges for the NGS reports where you are outsourcing?
Yeah, ma'am, definitely that remains a big problem. Sending an NGS to TMH Mumbai takes a significant amount of time. There is transport time involved. A pathologist needs to evaluate again at Mumbai before marking the area for testing the tumor and testing. So that is a big problem. So we are working very hard so that we can start molecular lab, fully functional molecular lab. Till now we have RT-PCR and other tests, but we are working very hard to start NGS at our institute.
Thank you so much. We move on to the next speaker, Dr. Vidya Veldore, who